Thank you very much, Michelle. It's a pleasure to be at the Fox Theater this afternoon and be able to introduce and moderate this panel. In a lot of ways, this panel to me is a culmination of everything that we're talking about today. Dr. Dente talked about the importance is that you're making a difference in the lives of patients. And all of the health IT in the world is great, but if it's not doing you any good with patients and not affecting the quality of the citizens of Georgia, it's not doing a whole lot of good. These three very distinguished women are going to talk to you about three projects that they head up that are making a difference today in the lives of Georgians and hopefully in the lives of citizens all over America. Sherrie Williams will be addressing you first. Sherrie, LCSW, is Program Director for the Med Clinic. She does a lot of school-based health and is very, very passionate about school-based health clinics as a delivery model. Dr. Ann Patterson is focused on bringing maternal fetal medicine to rural Georgia. Originally, her background is in aerospace engineering with a degree from Georgia Tech. She got her MD and OBGYN residency and maternal fetal medicine fellowship through the Emory School of Medicine. Finally, Dr. Reynolds is the Executive Director of the Chatham County Safety Net Planning Council, and she's the Director of the Chatham Health Initiative. She got her MD through the Medical College of Georgia and a Master's in Public Health from Mercer. In the interest of time, since we're up against a hard break this afternoon and the Lieutenant Governor is coming in, I'm going to turn the stage over to these three distinguished women.
Good afternoon. I am Sherrie Williams. I am a licensed clinical social worker in Georgia and have just started a new project down in Nashville, Georgia, Berrien County. And the question of the night, last night and of today is, where is Berrien County, where is Nashville? If you go take I-75 straight down, we're 30 miles north of Valdosta. You can't miss us, but if you blink, you may. So I'm pleased to bring you the project that we started last August. It's our school-based health clinic. And just to kind of give you some background information on school-based health clinics, basically what a school-based health clinic is bringing comprehensive care, including medical and mental health, to the campus so that the students have access to it 5 days a week, 8 hours a day, as long as they are in school. There's several different models of school-based health clinics. There are a couple in Georgia that are doing face-to-face only, and they're not using telemedicine. In rural South Georgia, where we're so isolated, telemedicine was the only model that made sense for us, so that is the model that we're using. And this is just a sampling of school-based health clinics across the nation. And as you can see, Georgia is way at the bottom with 5 little tiny school-based health clinics. 2 of those belong to Berrien County. 2 are in Atlanta, and just more recently, we had one open up in Ware County, which is way across Georgia. Of those 5, 3 of them are using a telemedicine model. And I'm proud to present to you our med clinic. The reason we decided to start a med clinic, a school-based health clinic in Berrien County, related to several factors. Number one factor being that we are so isolated from any regional medical centers. The closest medical center to us, other than our tiny local hospital, is 30 miles away, one-way trip. So if someone needed to see a specialist, they would have to travel out of the county, and at a minimum, they were looking at a 60-mile round trip. Well, given the climate of the economy and the fact that we are so isolated, many of our residents don't have transportation. If they do have transportation, they don't have the financial resources in order to put gas in their car to make it to Valdosta or Tifton and then make it back to Nashville. So that was the number one driving force behind doing a school-based health clinic. Number 2, there are no specialists in our area. We have 2 local physicians in our county. Neither one are pediatric doctors. They are general practitioners. Psychiatry it doesn't exist in our area. And if it does exist, you're driving the 60-mile round trip, and chances are those doctors are already so full they're not taking on any new patients, especially those with Medicaid. And in doing a needs assessment, we discovered that many of our children are not receiving regular health care. The next big question is, well, how do you find funding to do something like this? This is a school system. We know what budgets look like. We know there's not funding out there. Our school nurses each year get cut a little more and a little more and a little more. If we're not careful, they're going to be a thing of the past. So we had to get kind of creative in where we came up with our money. So we went on the funding hunt. Georgia Partner for Telehealth was a huge funding partner for us. They helped us with equipment, training us on the equipment. Emory University has a wonderful, wonderful school-based health initiative going on now. It's called the Urban Health Initiative, and we were able to receive $15,000 from them, and this is an ongoing source of money. If anyone was interested in starting a school-based health clinic, this would be my advice to start. The RFP comes out every spring. It's on their website, and it's a wonderful way to get started. Healthcare Georgia Foundation, the Governor's Office for Children and Family is the current grant we're working off now. It's the Systems of Care grant. And then we recently received a HRSA grant for $403,000. This is our integrated student system of care. When we started thinking about school-based health clinic, we were like, how are we going to offer these services? There are services that are already there. The school nurse clinic is there. We have special education services. We have the school counselor. But we kind of wanted it to make sense. So if you're familiar with the education system, there is a tier system for special education. It's tier 1, 2, 3, and 4. And it's built in a pyramid, just like our model. And the reason we chose the pyramid was because when we were talking to educators, we wanted to have something that made sense to them. So putting it in this format helped it to align with the education system. At the bottom, you have the services that are offered to the entire population. And then as you go up, of course, it gets more and more specialized. And at the top, we have the medical, psychological, and therapeutic services. And literally what we're doing is bridging the gap. In our triangle here, you can see the student and the family is the center of everything that we do. From an educational standpoint, we have after-school programs that are offered through the Boys and Girls Club, and then we have academic support services offered through our special education that happen during the school day. That's cut off on my screen. I'm not sure if it's cut off over there or not. But in terms of mental health, I'm the on-site licensed clinical social worker, and as kids sign up for the school-based health clinic, they are eligible to receive services through me. We also have our school social worker and our guidance counselor who provide services. And then in terms of physical health, we were lucky enough to partner with 2 of our physicians, one in our county and another physician in the adjoining county, who were willing to give us a 3-month shot at our school-based health clinic. They agreed to join us for 3 months. We'll see how it goes. We'll see how it impacts our practice. And if it works, then okay, maybe we'll play with you. If not, then see you later. Well, we're a 1.5 years into it, and we still have both of those doctors with us. It's tremendously impacted their practice in a positive way. A lot of times when I'm talking to audiences with physicians, the physicians say, how do you work it into my already packed practice? I can't see who I have. The way we've been able to work it is as an acute care walk-in clinic. If it were after hours and your child became ill, rather than taking them to the emergency room, hopefully you would find a walk-in clinic to take them to. And that's the exact same philosophy we have in the school system. We see kids as they're sick, they come into the nurse's clinic, we call the doctor, and the doctor works them into their schedule as if they would work them as they came into their office face-to-face. As I said earlier, telehealth is changing the way we think about healthcare in small rural counties, especially with our children. I can't emphasize enough, the whole reason to do this is to provide quality, accessible care to our children. It has been a phenomenal success. Some days it's way more busy than we can handle because the word is getting out, people are excited about it. And when we first began the project, people are like, telehealth, what is that? I'm not comfortable seeing a doctor on television. But as they became a little more accustomed to it, and we showed them bits and pieces of it, and I'm convinced if you can see your own body part on television, such as your eardrum, you're sold. And this is just some of the clips from our clinic. Both of the physicians we work with say that they had rather see the images of an eardrum, a throat, with this technology than in face-to-face, because when you're looking through an otoscope with just your bare eye, you're getting an image, about this big, and here they're seeing it on a 46-inch television screen. It's huge, it's clear, it's just a beautiful, beautiful image. And it's interesting when we have parents in the sessions, they're able to see their child's eardrum, and you can explain to them, can you see the discoloration, the red? This is what's happening. You know, smoking in the home can cause your child to have ear infections, and this is the result. So we use it also as an educational piece for the parents. Over the past year, we have seen many outcomes, and the most exciting ones are we've had a decrease in student absenteeism at our elementary school. We started at our elementary school, which is 3rd through 5th grade last year, and we've seen a 4% decrease in the students missing 15 days or more in that school. There's not any hardcore data that says the school-based health clinic is what has caused this decrease, but when you look at the system as a whole, the only change the entire school system made was introducing the school-based health clinic. So we were pretty confident that's the reason that the absenteeism has gone down. We also offer services to teachers and the staff there. They are also missing less work because they can see the doctor on campus. You know, the nurses, the teachers have to drive 60 miles also to see the doctor. So when they leave in the morning, if they have an 8 o'clock appointment, they're leaving early in the morning, they're sitting in the doctor's office waiting room for a couple of hours, they go back and see the doctor, and they've at minimum missed a half day of work that we've had to pay for a substitute teacher to come in. So by being able to provide these services on campus, the teacher stays in the class longer, and we're not having to hire a substitute teacher to come in their place. And we've also had a decrease in local ER visits. We were looking at asthma specifically, and we contacted our local hospital. They looked at their numbers of students who were in the age range of 9 to 11, which would be our elementary age level, and what was the decrease of ER visits in those children with asthmatic attacks. Prior to, there were 20 some odd students from our school who had presented in the ER with asthma attacks. When the school-based health clinic finished its first year, we went back, looked at those very same age group of kids, and there were one child presented to the ER with asthma symptoms. And I know that that is a direct reflection of the school-based health clinic. We are addressing asthma on a daily basis. We've started an asthma management program. We're able to help these children get the medication that they're needing. We can oversee their medication, make sure it's taken appropriately. So I truly feel like the school-based health clinic has made that huge difference. And we had a video to show, and I'm not sure that it's going to work. So it's not working, so I told the guys to end my show, I would just sing and dance for you, but I will spare you the pain, and I'll turn it over to Dr. Patterson.
Hi, I thought my slide was going to pop up here. There we go. Oops, went too far. As Taliaferro Smith said, I do maternal fetal medicine. And for those of you in the audience who wonder what in the world is that, it's 3 years of training post-OBGYN. So it's one of the subspecialties, and you have a fellowship. There are 2 others, GYN oncology, which is the cancer specialty of OBGYN, and reproductive endocrinology, which helps people get pregnant. I had had a practice of maternal fetal medicine in Atlanta for 20-odd years, and a couple of years ago I decided I wanted to do something different and decided to change how I practiced. There are, so you'll know, about 1,500 people in this country that practice maternal fetal medicine, and that number has been stable for 20 years because the attrition rate is about the same as the number of new grads, which is 3 years post-residency. In Georgia, there are about 25 of us that are board certified, a couple that practice that are not board certified, and they are clustered either in the metro area or in medical centers throughout the state, but none in rural Georgia, essentially. There's one in Albany, there's one in Macon, there are a couple in Savannah, and everybody else is north. So when I decided I wanted to do something different, I partnered with 3 other people. 3 of us have worked together, all 4 of us have had a professional association, and we wanted to do something that would bring high-risk care to rural communities. And so our goal would be to try to keep patients at home in their communities and provide services that would address high-risk problems and keep patients from having to travel long distances. To do this, I am physically based in Habersham County, which is an hour north of Atlanta, and I often do the reverse commute. But I deal with patients in the office in a rural community, just like many of the patients that I see through telemedicine. That have the unique problems of living remotely from a city, Habersham not as remote as some of these. And our goal is to provide ultrasound, where we can do a store and read capability, where you can I can call up the ultrasound, read it, send a report, it's generated, it goes back to the doctor that day. I can do maternal fetal medicine consults, so I can actually see a patient live. She looks at me, I look at her, and you're going to see a video about this in a minute, where you can talk to the patient, she can voice her concerns, we can address whatever her problems are, and when she leaves that day, she has a better understanding of what's going on and what her plans are going to be. We can mobilize this and do lots of things. We have talked with doctors in different facilities. We've done rounds where they have different problems with patients they want to discuss. We can actually see patients that are diabetic on a certain morning and go over their insulin and their glucose values and what that needs to be adjusted. That's a very easy way for a large group of patients to be seen in a concentrated way. One of the people in our group, Lee Retorto, is a registered ultrasonographer in everything that's possible, both in adult and fetal. And she's had the ability to help ultrasound techs throughout Georgia in teaching them remotely, and has a module for teaching, which has been really helpful in getting people to be able to do better scans, which certainly helps me as well as the obstetrician and the patient. We are also going to have genetic counseling in the not too distant future, which will also be done through telemedicine. What happened was we wanted to develop this module to see what we could really make a difference in the state. For instance, Georgia is 41st and 43rd out of 50, so not very good, when it comes to low birth weight and preterm birth babies. And the only way you're going to make a difference in those numbers is to really address the problem where the problem is. In Atlanta, you have lots of exceptional care. In big medical centers, you have the same. But in smaller communities where you do not have that, you do not have the opportunity to impact those numbers or make a difference. And in the counties throughout Georgia, we have pretty good statistics, and we know which areas tend to have bigger problems. But as a whole, we need better care locally. So that has been our driving goal. And in doing so, we've been able to see that a lot of patients are rural, but we've also been able to keep 80% of those patients in their home, and so they don't have to travel. If a patient does need to be referred, then I have the opportunity to make that referral. There's records that can go, there are ultrasound reports as well as films that can go with the patient. So when she arrives at a medical center because she needed to be transferred, all of that is available to the accepting physician. And that has been very helpful. I think overall, as this begins to, I think as we see more and more patients, I think it will make a bigger and bigger impact on the state. As I said, we started about a year ago. We have had the telemedicine unit since about February, and since then we've done over 550 visits by telemedicine. And I think that in itself has been really both exciting and huge. One of the things that you're going to see the video of in just a second that I think may be the only one ever anywhere, but it certainly is the only one in Georgia. What we were able to do is identify a woman who was 5.5 hours from Atlanta in a rural community who had a baby with a heart problem. And we then have a link where the pediatric cardiologist at Children's Healthcare of Atlanta is also linked by telemedicine. We were able to scan the patient in her community. The ultrasonographer had been trained through Lee's help to be able to do a fetal echo that would be of the quality that you could diagnose and recommend what the patient needed. So she has an ultrasound, a fetal echo. Before she leaves the doctor's office that day, she knew the plans for her baby, what the follow-up would be, and she never left home. And I think that is really exciting. I think at this point it would be really good just to show that.
I'm Dr. Ann Patterson. I practice maternal fetal medicine. I have done so for approximately 25 years. Approximately a year ago, my chief sonographer, Lee Retorto, and I started talking about, wouldn't it be wonderful if we could bring maternal fetal medicine and ultrasound for maternal fetal medicine to small communities. And during the past year, I have started a new endeavor where I use a Mediport device developed by Seaport Solutions to provide consultation and ultrasound from medical centers that are remote from where I am. Well, when I first saw the equipment, I actually was a guest at Emory Genetics in Atlanta. I had seen through my engineering experience in the past some remote hookups, and nothing was as good or as sophisticated as what was presented at Emory Genetics. And so I actively sought out trying to get this equipment because I knew it was would make a difference, and it indeed was compatible with high-resolution ultrasound, which was very important. The Mediport allows us to do three things. It has a store and read capability so that a patient can have an ultrasound with encrypted data. It is sent and we can read that and the report is generated. We can also see a patient real time. She can have a physical exam from the presenting site, which we can see real time. And thirdly, we can do an ultrasound real time so that the fetus is evaluated while the patient is being scanned. And that provides us with the ability to look at and diagnose the fetus or get a real-time scan to look at what we need to. One of the things that this type of medicine and this type of equipment has given me the ability to do is to reach out to communities that would otherwise require the patient to travel a long distance to have the kind of care that we can provide. By doing so, I'm very hopeful that we will be able to help Georgia as a whole through helping rural communities.
Do you have the other video? Do you have the other video of the heart study? No? Okay. Sorry, there is a second video that really does show the two physicians and the patient. And the patient has the heart study of the baby. And that, I think that's the first one that's ever been done anywhere. There are only two other groups in the country that are doing maternal fetal medicine by telemedicine. One is out of Arkansas, one is out of California, but to my knowledge, this is the only time we've ever been able to diagnose through fetal echo. And I hope it's just the first we do. Thank you.
Hello from Savannah, Georgia. I am Paula Reynolds, and I am the Executive Director of the Chatham County Safety Net Planning Council. I think you're all familiar with the safety net concept. That's a group that may take on different components depending on the community that addresses care for the uninsured. So I have to tell you a little bit about that organization first so that you'll understand how we came to set up a community health information exchange. Our county is about 250,000, 150,000 of whom live in the city of Savannah. About 1 in 5 adults and 1 in 4 children in Chatham County live in poverty. 1 in 4 adults, 18 to 64, have no health insurance, but 1 in 10 children have no health insurance due to the availability of Medicaid and Peach Care for Kids. And our unemployment rate right now is about 9.2%, so that sets the stage a little bit. But since the mid-'70s, our county government has devoted a significant portion of their budget to indigent care, as they call it, and recently that has topped $4 million. So due to the efforts of a number of stakeholders in care for the uninsured, the county did mandate in 2004 that all those with a stake in it, including several social organizations and all nonprofits, both hospital systems and our system of providers, which includes 2 FQHCs and 3 volunteer clinics, as well as pharmaceutical assistance providers. They mandated that we get together as a council and evaluate what we're doing in order to work together to improve access to care and quality of care for the uninsured. We were brought together under the neutral convener of the Chatham County Health Department, as we are till this day. Now, we function by a series of annual evaluations that we voluntarily provide data to on behalf of the clinical partners. Also, then we'll do needs assessments if needed for a particular type of care, like dental care or even transportation. And then we hold periodic strategic planning sessions, one of that, the happy people, working together. Everyone in the council, except for me, is volunteer. We all have other jobs. And as I said, we're representing these various stakeholders, particularly at first, working with the emergency departments in our hospitals to try to get the individuals who seek primary care there to be linked to a medical home in our system. Actually, since 2004, we have tracked within the system that we have an increased access by 57% in the number of patients that we see and 81% in the number of visits that we provide. So we feel that we've been very successful there. However, in one of our strategic planning sessions in 2005, we realized that, yeah, we're really good at submitting data and looking at it, and we can follow trends. But we have an unknown amount of duplication in our system. In other words, a patient that might have been seen one place, we don't know how many other places that same individual went. And that's not to say anything about the patients, although in the uninsured group, they often go to the most convenient place for care. But we also, to find efficiencies in our system, we often didn't duplicate services. For instance, one provider might have a podiatrist that everybody could go to, so that we wouldn't reproduce programs and spend more money than we needed to. So we were cooperative in that manner. So we decided in 2005 to adopt the then new field, in our view, of health IT to help us through and solve some of our problems. So a little bit of our timeline. In 2007, we were named one of the HIE demonstration projects by DCH here in Georgia, and then proceeded to form an IT consortium under the heading of Chatham County Safety Net Planning Council, which had representatives from all of our clinical partners, the hospitals, and significantly a group called Savannah Business Group, which is a group of self-insured employers in Chatham County who represent about a third of the covered lives in our area. We worked the first year to encourage EMR adoption throughout the community and, of course, within the safety net providers themselves. To date, all of them have adopted EMRs or are at least in the process of doing so. And we got them through various grants that we applied for, because remember, we're all providers for the uninsured. There's no reimbursement or income that we're talking about here. So we also hired a consultant to help us look at various architectures and how we needed to design our infrastructure that we could solve some of our community problems. And we decided on the central model and released an RFP. Got everything set up. We actually host our own system with our own servers, et cetera. If you ever want to find out how to get something on a budget, talk to me. And we went live in April of 2010, and actually, since we had been reporting to the county and telling them of our progress, we have a permanent sustainability funding from the county. They actually fund the HIE on behalf of the uninsured patients in our county. Okay, so here is a little bit about this infrastructure that we've put up. This is for the safety net providers only. There's actually one that's left out now because MedBank, one of our main pharmaceutical assistance programs, has also gone electronic, so they will be a part of it as well. The two on the left, that J.C. Lewis Primary Health Care Center and Curtis V. Cooper Primary Health Care are our two FQHCs. Then we have 3 different volunteer clinics. We heard about the Alliance of Chicago. They actually got the grant through them to go electronic. Only one of them is portrayed there because they're both under the same heading. And then both of the EDs, and the red arrows there are the 2 pilot providers that volunteered to be the first to be linked into the system. And we, as the Safety Net Council, an independent nonprofit, we actually own and maintain and manage the system so that we're an independent non-provider manager. You also see a little bit about what we decided to have as the first data that goes in automatically: encounters, allergies and alerts, medication, lab tests, radiology studies. We also are working on a problem list. Let's go to the next slide and show you a little bit how that pilot has worked. All of our providers can have whatever EMR system that they want. This is automatic HL7 messaging into, I don't see the whole slide, I hope you do. The information goes into the integration engine, and then we have the central database that is overlaid by the master patient index. We have a very good EMPI right now, but we're going to a more robust one that I'm going to tell you something about later if I remember. Please ask me if I forget to tell you the other thing we're doing with that. Then all of the records are put into a single longitudinal patient record. So if Joe Smith goes to the ED, but Joseph P. Smith Jr. goes to the FQHC, and all of the other information is the same, his records are merged into one. And then at the end, there's a clinical portal where the authorized users can go in and look at that information 24/7. The scattered or federated model would mean that all of our providers would have to be up technologically 24/7, and their systems be available for query at any given time. So we very early on decided that the central database was better for us, especially since we want to look at a lot of data and do reporting out of the system as well. So eventually, after we link in all of the safety net providers, of course our system is robust and can grow. We have the ability to actually link just about anyone, anywhere into the system, and these are some of the providers that we've been talking to. We do have the EDs going in, but of course the inpatients, and you see all of the safety net providers in there. Public Health has been at the table with us from the very beginning, and they're interested in working with us, whether it's their own system of servers in our system, and that only a certain amount of data is exchanged or put in patient records, but then it could also all be available for research purposes. Then we have various private providers that could be local or regional. Hub solutions there, that would mean a lab hub, a pharmacy hub, a radiology hub. We heard about language and translation today. Those hubs actually provide that and could be linked into the system similar to a provider. And what we would provide for them is our EMPI capabilities. Then we're also talking to our jail. which has, for our prison health services, they have contracted with actually Prison Health Services, who wants to be able to put in the prison medical data into our system as well, because talk about a real break in the continuum of care. If someone is actually incarcerated and needs health care there, they really have no access to their previous records, nor does a provider have access to the records in prison or jail once they get out, and that is a real lack and a need. Plus, we're also talking to the mental health providers about linking in with us as well. And so what this does is create what we are now calling a health information infrastructure for our community and our region. It's not just exchanging information, it's creating a robust and sustainable infrastructure, because when you have this data in one place, you can actually have it so that the patients look at their whole record. We were talking about 200 medical files in 19 different places. What if you only had to go one place to look at all of them? And that is our goal, not only for the paying patients, but for the uninsured patients in our area. Now, with patient permission, providers can also access a complete record of everything that the patient allows them to look at, there are also alerts and warnings if the patient says you can't look at certain things. And then we are working on downloading subsets of the data into a separate system so that we can do some reporting and some research. Now, one of the things that I was going to talk about our EMPI, someone was talking earlier about the registration process. This is not the clinical portal. This is the front end, going into what we are calling our community registry. And you can also use just the demographic data so that everywhere the patient goes, that means that their record gets updated for everybody else whenever they present somewhere. It's a single click for any registration department to go into the system and see whether the patient who's standing in front of them is already in our system. And if they say, oh, you're Mr. Smith, I see, do you still live at 123 Garden Lane? Yes, that's me. Okay, click. They're registered because it downloads all their demographics. And what the system sends to the central database is just a log of the date, patient registered at X. Those individuals don't see any health data, but someone who's looking later, and actually really our database managers can, we call them data stewards, they can see if there was a mistake made where it might have been made, and sometimes there's a duplication. There is a little bit of actual management that has to be done to that system, but we do it on the behalf of all of the medical records departments in our provider network. We can also get modules to put payers on there so that if you had a family, they would be linked, and you could also see, okay, the children are covered under Peach Care, but mom and dad have this kind of coverage, and actually see the network of providers that actually fall under whatever plans they have. So we don't have that yet, but that's one of the things that we are going to do in conjunction with Savannah Business Group. So our goals, of course, is to develop a robust, sustainable health information infrastructure and continue to encourage the EMR adoption across our region. We want to link all of our safety net providers first. That's our first goal, of course. And we'll put them into Chatham Health Link. We want to have a trusted and valuable data bank of patient records, not only for providers, but mainly for the patients themselves. Because particularly in our population, a population that, unless something changes between now and 2014, at least a percentage of them may become insured. So we have health literacy to deal with, but we also have health system literacy that we need to teach them. We need to teach them what it means to be insured and how to advocate for themselves. So them having access to their record is not only for their health, but also to help them navigate a new system that they may become a part of. We also want to maximize enrollment in our area. I know that there are a lot of government programs out there. They may have higher enrollment now. Even food stamps, I know, working with DFACS, that they had a lot of push in the last couple of years to get people actually signed up who are eligible for them. So we don't want to have that problem if insurance programs become available for those who are currently uninsured in our community. Again, we want to engage patients, as I said, and we are also looking very seriously at that word accountability. Now, there is accountability for those who are paying patients, but we are proposing to our hospital systems and our specialists that they should start to work with us now. Because if they can find efficient ways to work with people where there are no reimbursements and figure out a way that we can participate with them and minimize the impact on the hospitals as far as a patient's continuum of care, and do it right the first time, then we'll be well on the way to being efficient for every other kind of patient that may come in. And why are we starting there? Because that's where we have the champion in our community with county government and the Safety Net Planning Council. We also have this big telephone and this big car that we're driving, so we want to communicate and be a part of any other technological advancement or anything else that people are using. I was listening to Sherrie and realizing that one of the things that we found in our evaluation that over the last 5 years, the snapshot of the individuals who visit the emergency departments for primary care has changed. It used to be adults, homeless, et cetera. Now, adults who are uninsured from Chatham County come within our system and they visit an average of 4.5 times a year, 4.5 visits. And the emergency departments tend to be children who are insured and often from other counties. So that seems to be a picture of someone who actually has a Medicaid provider but can't get in to see them. So maybe we need a school-based clinic in Chatham County. Sounds like it to me. But also, since both of our hospitals serve a 40-county area, telemedicine is very much on our radar, and we would love to be able to figure out a way to get those encounters into the patient's medical records, or at least a summary of them. And of course, we're working closely with the GHIE, DCH, and other service area HIEs in the state. So we have a lot of benefits for both the patients and providers in our community, and I like to think of us as the little engine that could, because we started on a shoestring with a mission in mind, and we have grown to be something we're very proud of in our community. Thank you.